Hello, YouTube. All righty then. Hello, my friends. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. We are going to be renaming the company soon. It's going to be probably the Interstitial Cystitis, Bladder, and Pelvic Pain Network. Get ready. We're going to start using new terms other than the word IC. Why? Because interstitial cystitis is a name was developed about 100 years ago when they thought there was a fundamental problem with interstitial layer of the bladder wall. Guess what? It isn't. And we've known that for years. So most of the world is no longer using the name interstitial cystitis. Rather, they're using the name bladder pain syndrome. The only people diagnosed with interstitial cystitis are going to be patients who have Hunner's lesions. So that's coming sooner rather than later. Get ready. Anyway, so my name is Jill Osborne. I'm the president of the IC Network. Every Sunday, I try to do a live support group meeting. Sometimes we have patients who come live. Other patients watch after the fact. Because IC support groups shut down during COVID and because most of them have not come back, this is it. And I'm happy to try to fill this need. Now, my job in doing these meetings is to educate you, to inform you, to empower you, to give you a kick in the butt if you need a kick in the butt, and let us move into a new direction, especially if you're not responding to treatment. Our guidelines say, if you're getting worse rather than better, if you're not responding to treatment, we need to stop what we're doing, take a step back, and revisit the diagnosis. Why? Because we're missing things. Doctors are missing things now. We now use something called phenotyping, where we're going to try to find the underlying cause of your symptoms so that we can treat those symptoms. Now, I want to say thank you. I did not do a support group meeting last weekend because it was the anniversary of my father's passing. And yesterday was the anniversary of my mom's passing. So it's been a pretty challenging week. So I'm pretty tired. So I hope you'll bear with me. But, you know, first anniversaries are always going to be the hardest. Hello, Donna. So, Donna, I went back to my original microphone. How is the sound on YouTube right now? I want to make sure the sound is okay on YouTube. And you guys, we're simulcasting live. If I'm looking here, I'm looking at Facebook. If I'm looking over here, I'm looking at YouTube. And Donna says it sounds great. Awesome. That's what I like to hear. So normally when I do these meetings, I do a little 30-minute spiel, 20-30 minutes, something new and interesting, something I find particularly interesting and fascinating. We have a lot of new research that's come out about IC in the last couple of weeks. And I am going to talk to you today about, let's see, how do I want to say this? Okay, so this is an interesting topic. For those of you who followed the IC Network for many years, oh, here, hold on a sec. My light is funky. Okay. All right. So for those of you who have followed the IC Network, you know that every spring and summer we cover the American Urology Association meeting. Why? Because this is the largest gathering of urologists in the world. 20 to 25,000 urologists come together. This year it was in San Antonio, Texas, where they basically take a lot of classes. They learn what the latest research is. They challenge each other. They debate each other. They make friendships. They make enemies. You know, it's urologists are just like everybody else. You know, we've got people who love what they do, people who don't like what they do. You've got people that are envious. We've got people who want to make a name for themselves. I mean, it's really fascinating. It's just humankind. So at AUA 2024, was yet again a phenomenal class on IC. Now, I wrote an article about it. That's going to be the lead article, one of the lead articles in my magazine that we'll be putting together this coming week. It's virtually done. And the title of it is called A Microbiome Inspired Theory. So last year, Dr. Lenore Ackerman introduced new research implicating a pathogenic bacteria, Lactobacillus inners, as a cause of bladder pain in IC patients. And during the AUA 2024 meeting earlier this month, she began her presentation by asking, quote, could IC be really reflective of some type of infection or problem that we are not recognizing because we are still using technology more than 100 to 150 years old? So, okay, so follow my line of thinking here. We have spent a decade trying to get people to stop saying you've got a UTI, because pretty much all the research shows that we have a normal biome. And even though it feels like a UTI, and even though, here, hold on a sec. I gotta fix my computer here. So even though it feels like a UTI, we know antibiotics do not work. We know that the overprescription of antibiotics is really quite devastating. And yet we know that there are forces online and various people who say, you all have a bladder disease, you all have E. coli, you all have a bacterial biofilm, you all should be on antibiotics. And we've really struggled with this perception, because now that we're doing phenotyping, we know that the great majority of patients have an underlying muscle and nerve problem. I mean, we know that now. But could some of you actually have infection? Could some of you actually have an infection that we have missed? Not all of you. We're not saying everybody has infection in any way, shape, or form. We know that the great majority of patients have a muscle and nerve problem, not a bacterial problem. But could infection be playing a role in some of your cases? So Dr. Ackerman blew my socks off last year, and she came back again this year with her new presentation. And I'm just gonna read to you some of the article that I've written. So one of the points she made is, you know, when patients come to a urologist for the first time, the patient goes, it's infection. It's infection. It feels exactly like an infection. And the antibiotics worked 10 years ago, 15 years ago, but they don't work now. But it's still infection. I still have an infection. And the patient is confused and the provider is confused, because yeah, you've got frequency, urgency, pressure, pain. We associate that infection. Certainly that's an infection. Another point that she makes is that when you study IC patients, they have what we call inflammatory markers. Inflammatory, not all, just some. An inflammatory marker basically means that inflammation is happening. That's basically a biological war happening. The patients who have the most inflammation are going to be the patients with Hunner's lesions, because we now know that that's in all likelihood viral infection for these patients. So what's interesting is that patients who have infection have inflammatory markers. Many patients with IC have inflammatory markers. So again, couldn't this be infection? Well, in the last 10 years, there has been a massive explosion in the study of the microbiome, the bacterial communities that have a symbiotic role in maintaining our health. There are resident microbes living throughout our body, and interestingly, they differ based upon location. New next-generation DNA testing has identified distinct communities throughout our body. You've got some bacteria that live in the bowel, some that live in the mouth, some that live on your skin, some that live in your vagina, and some that obviously live in your bladder. The challenge, though, is that urinary biome studies have not been done particularly passionately. There's been a lot of research with the gut biome. There's a lot of research with vaginal biome, especially for patients with bacterial vaginosis. But we're just at the cusp of learning more about the urinary biome. So what happens in the bladder, we have to kind of extrapolate from what happens in the bowel because we know what happens in the bowel. So in the bowel, a good, healthy microbiome produces neurotransmitters that interact with our nervous system. They outcompete pathogens for foods and resources. So in other words, if you've got bad bacteria and good bacteria, you want the good bacteria to eat all the food so the bad bacteria die. They help to regulate our skin health and epithelial junctions. They produce natural antimicrobial compounds. In other words, your own natural antibiotics that can kill pathogens. And they also prime our immune system. Dr. Ackerman said, we think these effects are also happening in the bladder, even though it's different tissue. But what happens when the microbial community changes, when the normal organisms living in the genitourinary tract are messed up and no longer supporting normal activity? Well, an abnormal community develops. We call that a dysbiotic community or dysbiosis. Dr. Ackerman said, we think these communities lead to changes in epithelial integrity, and maybe they allow some toxins in urine to seep into the bladder wall and cause changes there, including increased vascularity and changes in nerve sensitivity, general irritation of the bladder wall and the muscles and the nerves and all that sort of stuff. And maybe that is what is leading to some of the symptoms some patients are experiencing. So the question then becomes, well, how do we test our biome? Well, our challenge here is that doing a urine culture is old technology. A urine culture means grow. So when they do a urine culture, they take a little bit of your urine and they throw it on a culture medium, which is basically food, and they see what grows out of it. The fundamental flaw with a urine culture is not all bacteria eat that food. They just don't. And so urine cultures miss the great majority of potential good bacteria and bad bacteria that are happening in your urine and in your bladder. In contrast, next generation DNA urine testing doesn't try to grow anything. It actually breaks up all the bacteria that it finds, and then it harvests the DNA and it looks at the DNA to figure out what kind of bacteria are there. So pretty much everybody agrees that next generation DNA urine test is definitely the future. So what is next generation DNA urine test found in the biome? Now, I've talked about this before, but this is really, she makes really, really important points here. What the IC biome finds is that we have a normal biome that is less diverse. It doesn't have a lot of the good bacteria in it, but it has a lot, some of it, probably most of it, but it just doesn't have as much. But it doesn't have anything bad in it. It's just a less diverse good bacteria, and it has an overabundance of lactobacillus. Interesting, right? So she went through all the research. There are many research studies that continue to find that. And then she decided, Borea, that she wanted to replicate that in her lab. And she found exactly the same thing. Hello, Anne. Hold that thought, hun. Hold that question. So Dr. Ackerman is one of those doctors who I really think in 20 years could win the Nobel Prize. Her work with the biome and all that sort of stuff is absolutely fascinating. And so she found the same thing. She had less bacteria, less diverse bacteria, more lactobacillus. But she then looked at it based upon age. And what she found is that patients under the age of 45 were dominant in lactobacillus, just good stuff. Patients over the age of 60, those of us who happen to be a little bit on the menopausal side, postmenopausal side, we had a lot more bacteria, but again, it wasn't particularly bad. But then she broke it up based on phenotype. And she's the first researcher to do that. And so she looked at the biome of patients who had pelvic floor issues, and guess what? Completely normal. They do not need antibiotics. There is no sign of any sort of bacterial issue in the vast majority of IC patients, of whom the vast majority are pelvic floor driven. Patients who had pain beyond the bladder, not in the bladder, but beyond the bladder, so the IBS, all that other stuff, kind of the widespread pain, they had a very remarkable biome with lots and lots of different bacteria in it. And last research, what she was saying is that they were a little bit more dominant in E. coli, but now we know E. coli can do good things. E. coli plays an important role in the biome. So that's a little bit nebulous here. But here's what she found in patients who were primarily bladder-centric. They were dominant in a very specific bacteria called Lactobacillus inners. Now, she's the first to make this discovery. Lactobacillus inners. Lactobacillus is good, right? Lactobacillus is supposed to be good. The more lactobacillus, the better, right? Wrong. Lactobacillus inners is actually a pathogenic bacteria. It is gram-negative. It doesn't kill fungus like other lactobacillus does. It produces minimal hydrogen peroxide and produces toxins like a Gardnerella infection that damage tissue, that damages the cells of the bladder. Lactobacillus inners has already been associated with a poor long-term outcome in women with bacterial vaginosis. Those who are dominated, their biomes are dominated by Lactobacillus inners, they just don't do very well. Patients whose biomes are dominated by other better lactobacillus, like Lactobacillus crispatus, do much, much better. So now we're going, okay, well, this is fascinating. Nobody's really ever found this. Everybody's like, well, IC patients have a lot of lactobacillus. That's good. But it turns out it's actually a bad lactobacillus, Lactobacillus inners. So why does Lactobacillus inners grow? It is what I call what's the right word? Not spontaneous. It is the first lactobacillus to grow after antibiotics are used. And it consumes the space. So, for example, she showed research that showed, so it is an opportunistic lactobacillus that grows rapidly and dominates the biome when antibiotics have killed the other good lactobacillus. So think about all those people online who are saying you need to take long-term antibiotics because you've got a biofilm. Her research is saying, you know what? When you take the long-term antibiotics, you create a catastrophe, because you kill the good bacteria and you're allowing pathogenic bacteria like Lactobacillus inners, and that's Hiloretta, I-N-E-R-S, Lactobacillus inners, to dominate. Now, what else happens after antibiotic use? What else happens after we destroy the good bacteria? Fungus grows. Because the normal job of good bacteria is to control fungus, like Candida. But when you kill the good bacteria, what happens? The fungus prospers. And it was our own MAP research network, our National Institutes of Health funded IC research team, that has already made the correlation with high levels of fungus and high levels of bladder pain in IC patients. The greater the fungus, the higher the quantity of the fungus, the more intense the bladder pain. Fungal signatures correlate with bladder pain. Specifically, Candida increases the pain overall. Okay. Now you got to remember, she's teaching the class of several hundred doctors who are trying to learn more about IC at the AUA meeting earlier this month. How did she end? She basically begged them to be much more discriminant when using antibiotics. She said, she ended her presentation with a cautionary note to the doctors who attended. Antibiotics are not harmless. She said, quote, there are systemic effects for antibiotics, which might include the enrichment of species like Lactobacillus inners and the overexpansion of fungal species like Candida. These may have long-term, very long-term, bigger consequences that we must keep in the back of our heads when those patients call who say, hey, doc, I've got a UTI. Can I have antibiotics? Now, I have said for years, if there is a group of patients who are, oh, hello, Vicky from Ireland. Nice to see you, hun. I have said for years, if there is a patient group that has been over medicated with antibiotics, it's the lower urinary tract IC patient. We all have taken massive levels of antibiotics. I can still remember being told to swallow 16 Septras or sulfas. Hi, Renee. And when I was in 7th grade, when my symptoms began, what did that do to my biome? What did that do to your biome? Now, she explained in this presentation that much more research is needed to study the urinary biome and how it changes in lots of diseases, including quote unquote IC. Dr. Ackerman said that an overabundance of Lactobacillus inners and Candida could be playing a role in bladder pain, but not in pelvic floor pain. And she talked very specifically about phenotyping. We have to, she urged doctors to get on board with this concept of phenotyping, because she said, until we agree on the phenotypes, we're not going to be able to do really good research. And thankfully, most people are starting to agree on the phenotypes around the world. So I've been talking about phenotypes for the last 7-8 years, Chris Payne's 5-point system. The big researchers combined some of Chris Payne's. Oh, there's a big squirrel out there looking at me. Hello, squirrel. We've got bladder wall pain, and in that is Hunner's lesions and estrogen atrophy and chronic UTI. We've got widespread pain, which are the multiple pain conditions. That's a systemic top-down issue. And then, of course, we've got pelvic floor-driven pain. The blessing here, the true blessing here, is that this is a tremendous moment of change in the IC patient population. This means that more and more patients are going to be given the right treatment for their unique case. It means that we're going to stop assuming every single patient who has frequency urgency has an infection that should be treated with antibiotics, because a lot of those symptoms can be driven by the pelvic floor. But for those patients who have infection, we've got to find the infection and treat it correctly. And what we don't want to do is just spray antibiotics like flamethrowers on our biomes. I mean, so anyway, truly amazing, amazing presentation. This is the future. Now, we also had quite a few more research studies that were presented. I actually kind of went through those a couple of weeks ago in stream, so I won't do those again. There is a tremendous lecture on estrogen atrophy, genitourinary syndrome of menopause. That's a personal cause of mine. I will be summarizing more of that in the future. And the blessing here too is that we can watch. I can watch them all on demand. You can't, unfortunately, because you have to be registered and you have to be a medical professional. But that's my job, to summarize them for you. So Dr. Anne Lenore Ackerman, UCLA, mark my words, she is a major agent of change for us, and things are looking very, very good with her working on our behalf. If this is the time to ask questions, believe me, I could talk forever on all sorts of interesting things. This is what I was working on this weekend. This week, in between bouts of crying, because it was a hard week for me. this is just critically important to us now. And my goal here, when we put it in our magazine, is for those of you who get our magazine, I want you to take it to your doctor. And I want you to help educate them that, you know what, we are finding something, but it's not this deep biofilm that people are talking about. And it's not suggesting that we use long-term antibiotics. In fact, it's saying, please don't use the antibiotics to any great degree, because it's the antibiotics themselves that are probably causing part of these problems. And of course, this does not apply to the patients whose symptoms began after they fall and broke their tailbone or they have a pelvic injury. This is just a very, very small subset of patients. All right, here, Anne says, so will exercises cure costidynia? That's all my physical therapist wants to do. She also told me to stop using my pelvic wand. I've used it for 4 years. Any reason why? I don't know why. I mean, I think that would be a really important question to ask her. That doesn't make a lot of sense. That doesn't, because I think that it's very important that we learn how to do our own therapy in a way so that we're not so dependent upon a physical therapist. If we have a pelvic floor flare, if we can recognize that flare beginning early and we can use a wand to massage that muscle out so that it does not progress, that's only good. So I don't understand why she would want you to stop using your pelvic wand unless you're doing something wrong and or you're hurting yourself in some way. Doesn't make sense. Meredith says, I'll tell you, I've got IC and pelvic floor dysfunction. I'm too tight. Anyway, I tried and then received the InterStim implant, Axonics. It is a game changer for me. I went from potting 20 times a day and leaking like a rusty faucet to 6 to 7 potties and dryness. Obviously, this may not be the solution for all, but it is something to consider. Here's to a flare-free week or month. Congratulations, Meredith. So during the class on IC, which was also taught by Quentin Clemens and Dr. Henry Lai, I mean, they're really kind of our top guns in the IC world now. They're the ones who are teaching these courses. They presented InterStim in a way I hadn't really heard anybody else say it. So as we're thinking about our treatment options, and we want to subtype that patient first. We want to figure out what phenotype they get into so that we can target them correctly with the correct therapy. So Hunner's lesion patients, Hunner's lesion therapy. Bladder wall patients, probably going to be doing some bladder installations. Pelvic floor patients going to be doing some pelvic floor physical therapy. And widespread pain patients going to be doing systemic strategies that will calm the entire nervous system down. Well, so he was talking about neuromodulation, and he said, and don't quote me on this, I'd have to go back to my notes. The goal here is to give the patient a benefit they need. Our guidelines are really relying now on shared decision making. They want the doctor to talk to you about the pros and cons of your treatment options. And then they want you to be vocal in saying, what do you need? What will give you relief while we try to fix us? And he said very specifically about neuromodulation InterStim, listen, if that patient is going to the bathroom every hour, every half hour, and they cannot get through a meeting at work, and it's affecting their ability to work, that's where InterStim makes total sense. Because if InterStim can reduce that daily frequency from 30 times a day down to, as Ann said, like 6 times a day, then that's a win for the patient. Because that gives you the symptom relief that you need so that you can do the work you need to do. Now, of course, again, that doctor is supposed to educate you about the pros and cons, risks versus benefits. I'm not saying InterStim is easy. It's not. There are a lot of potential adverse events with InterStim. But that said, there is a place for neuromodulation. And so, Meredith, you are the perfect example of that. The fact that it has helped you tremendously with your frequency. You just have to really watch it. If there's anything that feels unusual about it, if you're starting to get a shocking sensation, if it feels like things are starting to move, anything funky like that, you definitely want to be very, very vocal and talk to your doctor about that. Okay. Loretta said, I've been battling severe dry mouth, sore burning syndrome. Doctors tell me it's a result of Cipro, such a nasty antibiotic. Are you still on the Cipro, hun? Or are they calling this a neuralgia from the Cipro? Because menopause can also cause a very, very dry, painful mouth, what we call burning mouth syndrome. Is anything working? I do really well with xylitol, Xylamelts. And so whenever I start to struggle with dry mouth, I suck on some Xylamelts to just try to keep things fairly calm and copacetic in there, because dry mouth hurts, just like dry vulva hurts and dry vagina hurts. Dry mucous membranes hurt. So I'm really sorry that you're going through that. Keiko says, I have a question about Hunner's lesions. I was diagnosed with them. They were seen with hydrodistension and eventually got fulguration. My last scope was without a hydrodistension and she couldn't see them, but my symptoms are still the same, if not worse. Is it possible they are still there but not able to be seen without a hydrodistension? Or is it likely the symptoms are now coming from something else like pelvic floor or nerve pain? Oh, Keiko. If they have the correct equipment, specifically a flexible cystoscope or something called narrowband imaging, they can do a cystoscopy in the office without a hydrodistension to look for and find and see Hunner's lesions. So we had, in fact, it was Dr. Lai who published what he called an atlas of Hunner's lesions, lots of different pictures of what Hunner's lesions looks like, because some doctors are not able, they just don't have enough experience to be able to say, yeah, that distinctively is a Hunner's lesion. Hunner's lesions generally have a little red spot in the middle, and then kind of arms that radiate out, arms of inflammation and redness that radiate out from this red spot. But healed Hunner's lesions can be whitish. So concept number one here is maybe this is a good thing. She did the cysto, she just didn't see anything like she saw before. Great news. That's concept number one. Concept number two is that maybe it's a very small lesion that's not visible to the naked eye. Maybe there's something a little bit funky about it. But I would want to know a lot more about your symptoms, hun. Can you tell us a little bit about your symptoms? Number one, are you sleeping through the night? How often are you urinating? And where is your pain, if you have pain? Tell us a little bit more about your symptoms. That will help it. So, for example, a good example of nerve pain is pain that has a pins and needles sensation, pain that has areas of numbness, or if you have pain that shoots down your leg, or if you have a vibration, a fluttering, which I get frequently, or if you have persistent genital arousal disorder, where you feel the slight arousal sensation that's really quite disgusting because it also hurts and you do not want to be aroused. Those are the classic symptoms of somebody with kind of nerve-centric pain, pudendal neuralgia. Another thing we're going to look for is, do you have pain when you sit down that gets better when you stand up? Anytime we have positional symptoms like that, we're always looking at muscles and nerves. Bladder wall pain tends to be very sharp. It's like razor blades, ground glass. It really hurts. Bladder pain is characterized by being relentless and difficult to ignore. It's very hard, very, very hard to ignore because it kind of pounds away at you. I described my bladder pain that it was kind of like somebody was cutting my bladder wall with razor blades. It was that intense. Pelvic floor pain is duller, it's achier, it has a burning sensation. A lot of times that burning is confined to the vagina. It tends to be a little bit deeper rather than a little bit more shallow, although it can be shallow too. Sometimes pelvic floor pain or pelvic floor tension is manifested as a pulling sensation or a pushing sensation. And so I felt like somebody was trying to push something very wide up my urethra or up my vagina. I was working with a patient this week when I was describing that to her, and she goes, "That's it. That's exactly the pain I'm having." I'm like, "Yeah, that's pelvic floor pain for sure." Or it can be a pulling sensation, like something's being pulled out of you. But again, achy, duller. Whoa. Hey, that's my new phone thing. Here, hold on. Somebody's calling me right now. All right. Greta Van Fleet. I'm in love with the band Greta Van Fleet right now. So tell us, okay, she says, I get different types of pain. In the flare, I get sharp pain and pressure feeling in the base of the bladder. I get irritated feeling like my bladder is never quite empty. So Keiko, does it feel like your bladder's full even when it's empty? Like you just feel this desperate need to urinate, but when you go and sit on the toilet, nothing comes out? You get a cramping feeling after emptying your bladder. Okay. Bladder wall pain is characterized by pain as the bladder fills with urine that immediately improves when you empty your bladder. So the fuller your bladder gets, the worse you feel. You're desperate to find a bathroom. Once you find a bathroom and you empty your bladder, the pain goes away and you're like, oh, thank God I found a bathroom. So bladder pain is very dependent on volume. The fuller, the worse you feel. So pain before urination that gets better, bladder pain. Pain after urination, we really associate far more with the pelvic floor. Hi, Heggy. Oh, thank you so much for the 200 stars. Really, really appreciate that very, very much. Thank you so much. Keiko says, yes, I get that. My pain goes right down after emptying your bladder. So I call this the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. They're both involved, but one is normally driving the other. And so our job is to really try to figure out underlying causation. So for some people, IC begins during chemotherapy. And so the chemicals of the chemo really badly damage the bladder wall. And so the bladder, urine is now getting into the layers of the bladder wall, irritating nerves, irritating everything. And that pain is sent back up to the brain. And basically your muscles get tight to protect you from the pain. That's called the guarding reflex. And so for that patient, our therapeutic priority is to figure out what's irritating the bladder, get rid of what's irritating the bladder, and give the bladder time to heal. And we hope that that muscle tension from that bladder pain gradually reduces and goes away. That's the smaller group. The far bigger group of patients are patients whose symptoms began after a muscle injury. You just didn't know you had a muscle injury. And so let's just say, for example, you fell. And you might have fallen a couple of years ago. One of the symptoms that you just thought was kind of normal was pain with sex. A lot of women have pain with sex and they just think, yeah, sex is supposed to be painful. One of the ways we know that muscles are getting funky is that when you go to urinate, you can't start your stream right away. You hesitate 5, 10, 15, 20, 30 seconds. So now we have a patient, they've got tight muscles, they're struggling to urinate, and it feels like a bladder infection, frequency, urgency, pressure, pain. So what do? They call their doctor. Hey, man, I got a bladder infection. Doctor goes, okay, here's some antibiotics. You take them, they don't get better. Doctor goes, we better do a culture. They throw the culture out. I mean, you go down there, you leave your urine sample, the culture comes back negative. But the doctor goes, maybe you missed it, gives you long-term antibiotics. They don't work. 6 months later, it happens again. You go back to the doctor. The doctor goes, oh, maybe you've got overactive bladder or prostatitis, and they give you overactive bladder or prostate meds. They don't work. You go back to the doctor a year later, 2 years later, the doctor goes, oh man, I hate to break it to you. I think you've got this incurable bladder disease called interstitial cystitis. Here's the diet. Here's some antidepressant. Here's some Elmeron. I'll see you in 6 months. And you legitimately want to get better. So you do everything. You follow the diet. You take the meds for a month, 3 months, 6 months, 9 months, a year, 2 years, 5 years, 10 years. But you don't get better. You still flare. Why? Why do you still flare? Because for this patient, bladder therapies will never heal them, because the underlying problem is actually with their muscles. And this is 85% of IC patients now. I mean, that's a figure that they're using consistently now in these conferences. It feels like it's your bladder. It's not your bladder. It's very, very tight muscles that are restricting blood supply. So if your bladder is supposed to get 24 units of blood a day and it's only getting 10, are you going to have a healthy bladder wall? No, you're not. Our therapeutic priority for this patient is to restore blood supply. The way we do that is by relaxing those muscles with physical therapy. And that is why our national guidelines are very clear and say any patient with pelvic floor tension should be sent to physical therapy. Let me get a drink here. I don't know about you guys. Allergies this year are probably the worst in 20 years. They're so bad. The last couple of weeks here in Northern California, just constant congestion, no sore throat, just runny nose, sinus headache, irritated tonsils, you name it. So I did a big walk this morning and now I'm paying for it. The more I talk, the more irritated my throat's going to get. So Kako, you're right. You have both bladder and pelvic pain. You do. So if I were in your shoes, I would want to go to physical therapy. I would want to have a pelvic floor assessment, and I would want to know what's going on with my muscles, because that's the missing piece here. Have you been to therapy yet? If yes, what did they find? Lori says, will microgen DNA urine testing show fungus and bacteria? It will. That's the advantage of it. Who can read the results? Any doctor can read the results if they've been trained to read the results. Lori says, any tips to write in my appeal letter to my insurance who denied me more physical therapy visits? Yeah, Lori, I think I'd give them the research study. I think I would give, if you go to the IC Network website and you go to our physical therapy section, at the bottom of that section, I have a link to the federally funded MAP Research Network study that proves that physical therapy is effective. And in the class they just taught, they said typical physical therapy is 8 to 12 sessions. They said that patients who have had pelvic floor tension for a longer period of time may need more physical therapy than 8 to 12 sessions. There is always a chance that you can re-injure those muscles and need more physical therapy. So, Lori, you can always email me this week, and my email address, icnetwork@mac.com. I would be happy to write a sentence or two for you that cites that research. Okay. Diane, my uro wants me to do InterStim 2. Has it helped with not getting up to urinate at night? I'm up here. Hold on. I'm up 5 times most nights. I have tight pelvic floor and bladder pain when it fills because my bladder is sensitive because of inflammation too. Do you think InterStim will help with that too? I go often because my bladder hurts. Diane, have you had a hydrodistension? And if you have, what did they see in your bladder? Because anytime we see that level of frequency and urgency, especially at night, we want to make sure that there's no Hunner's lesions there. We also want to understand that nighttime urination is often a direct reflection of something that's irritating the bladder every day. So if, for example, you fall into the estrogen atrophy phenotype, that means that you're either on strong birth control, or you're on Lupron for endometriosis, or you're in your 40s, 50s, 60s, or 70s, and you don't have the estrogen you need for your bladder to produce that nice thick coating of mucus that normally protects your bladder. So for these patients, diet is everything because they don't have that thick coating that normally protects that tissue. And so for a lot of the patients that I've worked with in the last 30 years, that nighttime urination is a direct reflection of something that they're eating every day that they think is healthy, like green tea or soda, but green tea in particular. A lot of people think green tea is really healthy. Green tea is as bad, if not worse, than coffee. A multivitamin could account for and would create that foundation for pain every single night, because most mass market multivitamins use ascorbic acid as their source of vitamin C. And so we got to rule out the easy stuff before you go to a surgical procedure like InterStim. We want to know, okay, are estrogen levels making your bladder more vulnerable? If so, are you following the diet? Are you accidentally shooting yourself in the bladder with food? And I would also want to know, have you tried the bladder installations, and have the bladder installations been helpful? An anesthetic cocktail is a great way to determine exactly where that pain is coming from. Because if they put some lidocaine in your bladder and it turns all your pain off, then we absolutely know your bladder wall is the source of the pain. Now we got to figure out what's wrong with your bladder wall. Is it estrogen atrophy? Is it a chronic UTI? Is it a fungal infection? Because if it's a fungal infection, InterStim's not going to do a darn thing for it. If it's a problem with nerves, InterStim might help. But InterStim is one more of a last resort now, because we want to make sure you get phenotyped correctly first. And that's what our guidelines say. If you're not responding to your typical treatments, take a step back, revisit the diagnosis. Let's see if we missed something. Could you have endometriosis on your bladder? Could you have a fibroid tumor pushing on your bladder? Could you have pelvic congestion syndrome? Do you feel a heaviness? Do you feel, as the day goes on, like you're carrying a bowling ball around in your pelvis? And it goes away at night, you wake up the next morning, you feel pretty good, but as the day goes on, the heaviness gets bigger and bigger and bigger. That actually is pelvic congestion syndrome, and that's completely treatable. InterStim will not touch that. Another really interesting cause that came out earlier this spring is something called a urachal cyst. If your belly button is tender to touch, if you push on your belly button and you immediately get bladder pain or clitoral pain or penile pain, that's fascinating. Now we found a few patients who actually have this, who have been misdiagnosed with IC. A urachal cyst comes from something called the urachus. And the urachus is a tube that connects the top of the bladder with your belly button. And every fetus has this little tube. When you're growing in your mama's belly, how does the fetus drain urine? Because they can't pee. So what happens is that urine gets drained up through this urachus tube from the top of the bladder, up through the belly button into mama, and mama's body gets rid of the urine. And so this urachus is like, it's long. It's long. Well, after that child is born, the urachus normally shrivels up, but in 2% of adults, it doesn't. They still have a urachus. They still have an open tube between their bladder and a belly button. And so if you're somebody who has wetness at your belly button, that's from your urachus. And you know what that wetness is? That wetness is urine. If you have a crusty belly button, you know, your belly button always has crust on it. Oh, that's a sign that we've got a little bit of fluid leakage. And again, so if you have pain when you push on your belly button, that's a sign that we're dealing with something there. And we have been dealing with one of our members, Kayleen, who shared her story, and it's absolutely fascinating. So we now have 3 patients that we know who appear to have some sort of urachal abnormality. Fascinating. So to summarize, we don't just want to jump on the bandwagon of InterStim. We want to make sure we've ruled out all the other stuff first, had a proper phenotyping first, because that's really if you're not responding to other therapies. Keiko says, mine started around the same time as autoimmune affected SI joint. She had ankylosing spondylitis, but also had a UTI, which didn't respond to antibiotics. So I thought it was treated, but 4 weeks later, I tested positive. Really don't know which came first at all. Keiko, how long ago was that? When did this all start for you? Was it like literally this year, or did this happen a couple of years ago? She says she's been to 3 physical therapists. The first one I saw just wanted you to do Kegels, which means she wasn't trained. I'm glad you recognize that. The other one only focused on external stretching. I saw a third one who said there was tension and found very tender points, which she did release one. I couldn't afford to keep going every week, so I now do the pelvic wand at home. Good. Okay, so Keiko, then we know you're pelvic floor centric. So that's important. And there are a number of patients who cannot afford physical therapy. The blessing here is you finally found one who did the proper assessment and told you what you're dealing with. But if you can just go like once every 4 to 5 months, and even if you have to pay out of pocket to make sure that what you're doing at home is helping, to make sure that you're making progress, I would encourage you to do that. Diane said, no Hunner's lesions. I have estrogen atrophy, but on estrogen cream for over a year and a half. The bladder installations used to help, but not anymore. All right. So Diane, the harsh reality for you and me is that we're never going to have a 20-year-old bladder. We're older, and even though we're using estrogen, our bladder is always going to be more vulnerable now. It cannot defend itself as well now because we don't have that nice thick coating of mucus. So diet really matters for us. It does. And I'm definitely noticing, I mean, you know, the vast majority of my IC symptoms have been gone for 10 years. You know, because we stopped doing bladder treatments because I have a perfectly healthy bladder. Once I stopped wasting time doing bladder treatments and started working where I needed to work, which is on my pelvic floor, that's when things started to get massively, massively better. And I will say that, so I had emergency surgery 2 months ago for my gallbladder, completely blocked. It was really bad. I had no clue. I just kept having pain between my shoulder blades that I thought was from working at the computer. And I'd had that pain for years. And it was getting really bad. And I thought, great, I probably have osteoporosis, something like that. It turned out all that back pain was from my gallbladder, and it's all gone now. Praise God, hallelujah. No more back pain, which is incredible. Incredible to have that gone. But I will tell you, my pelvic floor took a beating from me not doing anything for 4 to 6 weeks. And I can definitely tell, and when I do my wand work, my pelvic floor is a lot tighter. It's a lot more sensitive, and my bladder is now a little bit more sensitive too. And it really goes back to, I think, the trauma of having surgery and having to sit around for a lot for long periods of time, which really messes up your pelvic floor, et cetera, et cetera. So then my SI joint really started hurting bad like 2 weeks ago, going from sitting. So I've got an appointment to go have a steroid injection in my SI joint. Getting older sucks. I love my 40s. I actually love my 50s, but the 60s, yeah, not so much. All right, so for Keiko, this all began 2 years ago. Well, hun, so if you take us back 2 years ago, what was happening 2 years ago? Had you been traveling? Like, is there any event that you associate with the onset of your symptoms? What do you think triggered your symptoms back then? Do you have any gut instinct? Had you been traveling? Had you had a fall? Anything funky going on 2 years ago? I say that because I was working with a patient a few months ago. All of her symptoms began after she had spent a couple of months with her family in like Panama, somewhere in Central America. And to make a very long story short, she had a parasite in her bladder that was infecting her bladder wall. And her next stop was an infectious disease doctor. That she didn't have IC at all. She actually was in a hotbed with this, where this specific parasite was very dominant. She was swimming in brown, muddy waters, which I would never do. And hopefully she's better now. Hopefully they've got her on the right anti-parasitical medicine. Diane said, I also found out that my Uro does PTNS, so I'm considering doing that instead. Definitely start with the PTNS first. It's very, compared to $75,000 for InterStim, you definitely want to go for the cheaper one first, because 10 treatments at $245 a treatment is only $2,000. $2,000, $70,000 each choice. The challenge here is that you have to give it time with PTNS. Like I had my first 2 hours without pain at week 3 or 4. I had my first day without pain at week 7. Did it fix the underlying problem for me, my tight pelvic floor muscles? No, it did not. Did it calm my symptoms down and get me out of a very painful flare? Yes, it did. Heggie says, May 17th was our national day and we were out and about all day. It was so warm and I drank a lot of water. But the big problem was that I was not able to pee, especially not in a public toilet where a lot of people were waiting in line. I tried so hard, but it wasn't possible. So I had to wait until we were home several hours later and could use our bathroom while we're listening to running water. Oh, honey, yikes. Ooh, so the very first thing, really the most logical thing that comes to mind is that the drive was so long that your pelvic floor muscles went into tension as you got there, and you just weren't able to relax enough to release urine. And then, unfortunately, it was very, very painful, and you held it for a few hours more, which just got those muscles to lock down tighter and tighter and tighter. So that sounds like pelvic floor tension to me, hun. I think it'd be very interesting to see what a physical therapist would say about your muscles. Anne says, going to a new urogyno tomorrow looking for answers. I heard he was the best. Good, Anne. Good. Be the squeaky wheel. Anne says, do I think coccydynia can go away on its own? No, I think you have to work with the muscles, hun. Coccydynia usually happens after some sort of trauma to the tailbone. And so we have to make sure the muscles and the nerves and the tissues are healthy. All right, you guys on YouTube, you're being very quiet. Feel free to give me any questions, okay? Keiko said, I had the Marina IUD that shifted and gave you terrible pelvic pain. You had it removed, started having terrible SI pain due to autoimmune starting, and I had the UTI all in an 8-week period. Well, so I have terrible SI pain too. And the reason why I have SI pain is because my joint is very flexible. and it moves when it's not supposed to move. And my pelvic floor, my piriformis muscle locks down very tight to try to hold it together. And so my SI pain is an old injury that they correlate with people who play racket sports. And I was a professional tennis player for a brief period of time after college. That was my dream. I was pretty good, but not that good. And my physical therapist, I have my physical therapist who diagnosed me was actually the physical therapist for the women's the men's tennis team in the Olympics, and was also the physical therapist for Yvonne Lendl, very famous, a very, very famous tennis player about 25 years ago. And I have the exact same injury that he did because, if you're a tennis player, you step in, right? You step in with one leg, and then you put all your weight on that leg, and then you rotate all of your weight on that hip. So, yes, Renee, we're live. I'm live. Are you live? I'm trying. It's hard to tell. The internet's being a little bit funky here right now. Anne says, my physical therapist does not want to do internal for costodynia, just giving me tons of exercises to do 4 times a week. Yeah, but the internal therapy is a therapy which has been found to be the most successful. So I don't I mean, there are a number of physical therapists who say that they don't want to do the internal work, and that's just because they haven't received their full training. But what our research studies show is that it's the internal pelvic floor work, which is indeed the most successful work. There are some people who cannot have internal work for one reason or another. Maybe they've got a history of sexual abuse, history of rape, or maybe they've got really, really extreme vaginismus and their muscles are so tight you literally can't get a finger in their vagina anyway. And for those patients, yeah, they're going to start slowly for several weeks, start externally. But the goal is to try to get internal, because as soon as we can get internal, that's when we have a chance to work with those muscles directly and try to get them relaxed and released. Linda said, my doctor wants to do a urethral dilation. Opinion, urethral dilations are no longer done. They're very, very rarely done, and only in an instance when the urethra is completely blocked and the patient cannot urinate. I went through many, many urethral dilations when I was young. So if we go back to when I was in 7th grade, I fell and broke my tailbone. Of course, nobody really understood the consequences of that, what that would be to the rest of my life. It was just, okay, Jill fell and broke her tailbone. But all of a sudden, I couldn't sit through class without going to the restroom. And my teachers in junior high got very angry and complained. Then the nurse called my mother and said, your daughter has a problem. She sends me to the doctor, or she took me to a urologist, Dr. Andrew Thusen. Back then, he's long passed. And they all thought I had a terrible bladder infection. And they gave me 16 sulfa pills to swallow my very, very first appointment. This massive, massive dose of antibiotics. And then I was diagnosed with what they called a urethral stricture, that my urethra was very, very narrow. And it was very, very narrow. It was like trying to pee through a needle. I remember that. It was very, very hard to urinate. And so back then, what they did was a dilation. They just basically stick a metal sound right into this tight urethra and just force it open. And for the patient, it's no fun. I mean, I had a gas mask on. They numbed my urethra first, and then they just jam it in there, leave it in there for a minute or two. And while I was squirming and squealing, And then they did a rescue installation afterwards to try to numb everything down. And as Loretta says here, so also known as a rape of the urethra, I'll tell you exactly where that quote came from. So today, when we see a narrow urethra, instead of going, gee, let's just force it open, maybe we need to ask the question, why is it narrow in the first place? And for me, the reason why mine was narrow is because my pelvic floor muscles were very, very tight. Very, very tight. So the use of urethral dilations have fallen off in the last 20 years. They're really rarely used now. And again, only if the urethra is completely obstructed, because that would be a medical emergency. And if we need to force that urethra open to allow that person to urinate, by golly, they're going to do it. So a couple of years ago, probably 7-8 years ago, at the American Urology conference that I was at, I don't even remember which one it was at, there was a team of illustrious, it was Dr. Evans, Dr. Moldwin, and Christine Whitmore, who were doing like a Q&A on IC in front of a big audience. And an international doctor came in and asked, do you do urethral dilations anymore? And one of them said, no, we don't rape the urethra anymore. I mean, it came straight from one of the top IC doctors. We don't rape the urethra anymore. Today, we try to understand why it's narrow. And usually it's narrow because the levator ana muscles are very, very tight. So I don't even know how many I had. All I know is I was thoroughly traumatized by it. Would I allow a doctor to do it now? No. The only reason I would ever consider doing that was simply if I couldn't pee. But that's when they would basically stick a catheter up there and drain your, drain your bladder. That's why I always say, if there's one skill that's totally worth learning, it's learning how to self-catheterize. So if you ever find yourself in the position where you cannot urinate because your muscles are tight, you can self-catheterize on your own and at least empty your bladder out so that you can get to the doctor and not be in agony. But yeah, so urethral dilations, no, not so much anymore. Hello, Vesna from Serbia. Hello, hun. How are you doing today? I don't even know what time it is there. Well, I bet you're like 10 hours ahead of me. And so is it like 2 in the morning for you right now? Because it's 2 o'clock in the afternoon here. Loretta said, my doctor was one of those you mentioned that called it rape. I don't remember which doctor it was who said that. The other thing that one of the most controversial things a doctor said there have been so many things I could say. I mean, when you get a group of the leading IC experts in the world together, they don't always agree on everything. I mean, there's a lot of competition between them, and some have one theory, others have the other theory. Some say my medicine works, the other doctor says no, my medicine works, et cetera, et cetera. One doctor said, what do you do? And this was several years ago. If a patient can't afford your treatment, and this really arrogant doctor responded, well, don't you know healthcare is a luxury? And I was just appalled. I was so appalled by the cavalier nature of that. Healthcare should not be a luxury. Healthcare should be a right. And healthcare should not be dependent on how much money somebody has, in my opinion. But you know what? That's called socialized medicine. And socialized medicine, I was working with one patient who had to wait 2 years to see a urologist after her diagnosis of IC, and she had severe pain, and she was still told to wait 2 years. So there's no right way or wrong way. We just have to be our own best advocates and try to work with doctors that will listen to us, that will understand us, that will be kind to us, and that will understand that if we have financial limitations, then they need to focus on medications which are less expensive. And they have to, and you know, like I have so many dreams that I want to do. One of my dreams is, so like if I won the lottery, I have three things that I would do if I won the lottery. I'd set up a research foundation for IC, and I would fund Dr. Ann Ackerman would be my first funding study. Number two, I would have a foundation where patients who were low income could apply for support so that they could get physical therapy, 100%, and treatment. Because there's too much disparity out there. And it's very upsetting to me that there are patients who desperately need care who cannot get care or who won't get care. And then last but not least, I want to like buy an apartment complex, and I want to make it for people who are disabled. ICers, pelvic pain patients, especially pelvic pain patients who don't have children and who don't have people to support them, or who feel very, very lonely. Because I think that that's something that we all struggle with. We all have struggled with the fact that when you develop a condition like IC or IBS, you're stuck at home and your friends disappear. And you're isolated. You want to go to the movies, you can't. You want to go out to dinner, you can't. And that the loneliness and isolation of a new diagnosis like this is something that we all have to break, because it's not your fault and it's not my fault. We've done nothing wrong. We're just hurt. We're just hurt. You're hurt. I'm hurt. But see, I'm way better now. My injury healed. My muscles healed. And I have been pain-free for at least 10 to 15 years. But I do on occasion hurt my muscles again. And when I hurt my muscles again, I've got to go work on those muscles. And my muscles definitely took a beating, because of my surgery. There's no doubt about that. Heggy says, yes, I definitely have a problem with my pelvic muscles. I'm trying to relax them through yoga. I wish I could try internal physical therapy, but I also have lichen sclerosis, which makes that very difficult. You tear so easily. So Heggy, are you treating the lichen sclerosis with clobetasol? So you guys, lichen sclerosis is like a vulvodynia on steroids, literally and figuratively. It feels like really, really, really bad vulvodynia. And when you look at the skin turns white or gray. And so this normally pink or red skin gets very whitish and grayish because the blood supply is diminished. And so therapeutically, lichen sclerosis is normally treated with a strong steroid known as clobetasol. So have you been treating the lichen sclerosis with clobetasol, number one? And number two, are you doing your topical estrogen therapy to also try to help that skin be as healthy as it can be? And Vesna, it says it is nearly midnight in Serbia. Oh, well, thank you for watching, hon, because it's late for you. Renee says, how is my tailbone? My tailbone is broken and out of position. The tip of my tailbone broke off completely. And so my tailbone, so normally your tailbone curves between your legs, here, kind of like that, right? So my tailbone is kind of straight with a round knob at the end of it, where the break was. And it is what it is. I was sitting on the toilet like 2 days ago, and I leaned back exactly the wrong way, and I got that little sharp pain right there. I don't even remember, like I wasn't having the runs or anything like that. I was just dealing with a post gallbladder need to have bowel movements. That's what happens. If you eat fat after you've had your gallbladder removed, you get a dump of oh, come on, what's it called? Bile. You get a bile dump into your bowels and then you go to the bathroom. It's so annoying. Hello, Rahul. Nice to see you. So Renee says she sits on a donut pillow. Renee, the donut pillows, because they're round, are actually tend to cause more pain because they seem to put more stresses on the pelvic floor muscles that are kind of push them beyond their comfort zone. We tend to do better with a linear cushion. Let me get you a sample. So this cushion is really, I mean, you guys, I have bought so many cushions testing. I have probably bought 100 cushions in the last 25 years trying to find the perfect cushion for patients with IC, pelvic floor dysfunction, et cetera, et cetera. This design has been the best by far because it has a groove down the middle and each butt cheek is supported, but nothing pushes up against the nerves in your crotch. It doesn't push against the urethra, the clitoris, the prostate. And it also reduces strain on the vulva and on the muscles around the rectum. So if I'm ever having vulvar pain or rectal pain, man, this is my go-to. I would never sit on the on a donut. They just didn't work for me. Rahul says I can't hear anything. You guys, but the rest of you can hear me, right? Renee, you can hear me? I know the rest. Loretta says, I have a patch of lichens. It was biopsied to be 100% sure. Used clobetasol and I go into remission. It popped up at the site where I had a nasty episiotomy during childbirth. I get it checked. That's not surprising, hon, because that inflammation from that lichen sclerosus I can see that happening in an area where you experienced a severe trauma. And an episiotomy is the epitome of severe trauma to that tissue down there. And so that doesn't surprise me at all. Hold on one sec. We had a couple of other things that are worth talking about. We had a new antibiotic called Pivya approved for bladder infections. This is very, very exciting because we have so many bacteria now that are completely drug resistant to our normal sulfas, septras, that it's becoming a strain to treat them. And so to have a new antibiotic with a new mechanism of action, this one's called Pivya or pivmecillinum. Actually has been used in Europe for about 20 years. It's specifically to be used for treatments of E. coli, Proteus, and Staphylococcus. So that is a very, very exciting. So for anybody who does get a UTI, we're going to have a new treatment. Also, another thing that's happening with Pivya, although it is approved specifically for simple infection, they've got some of their first studies showing that it's also working in drug-resistant infections. So that's quite exciting. And then, hold on a sec. You're not going to like this study. Renee says, I'm so glad we need new antibiotics. Yeah, we do. Renee asked me, do I use clobetasol cream? No, I don't, because I don't have lichen sclerosis. I have a normal, healthy vulva. It gets dry every now and then when I forget to use my estrogen, but I do have clobetasol. I tend to use it for bites because I get wicked. My skin goes crazy with mosquito bites. Hello, Christine from Scotland. After 5.5 years, you finally had a urodynamics test. Everything passed the test, but it was mentioned to me that I should try high assist installations. The only thing that showed up was that my bladder muscle wasn't contracting how it should. I don't imagine I'll get the installations before September at the earliest. Still have constant infection-like pain, so it's been a long haul. So, Christine, how old are you, hon? How old are you? Because if your symptoms began, if you were on birth control, if you were taking Lupron, or if you're in 40s, 50s, or 60s, then we really have to look at the concept of estrogen atrophy as being an underlying driver of your symptoms. I mean, think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste. Well, we're the same age, girl. We're the same age. All right, so think about your bladder. It's the only organ in the human body designed to hold toxic waste. So how can the bladder hold ammonia for hours and hours at a time and not get damaged? I mean, it's really an evolutionary marvel. Well, it turns out the way the bladder defends itself is it has a really thick coating of a mucus. And that mucus acts as a barrier. It protects the skin. But that mucus is estrogen dependent. So when you're young and have lots and lots of estrogen, you have lots and lots of mucus. But at the age of 63, you and I don't have the estrogen anymore, which means we don't have much of the mucus anymore. And so I'm really glad you're using the estrogen cream. But because your bladder can't defend itself as well, even with the estrogen cream, diet matters. You have really got to be careful with your diet right now, because that's not a disease process. It's just a lack of protection. It's just dryness. I mean, if you have dry mouth and you drink a glass of wine, your mouth is going to sting like heck. Well, if you drink a glass of wine, your bladder is going to sting like heck if it too also is a bit dry. You've had this problem for over 30 years. Me too, girl. My symptoms started in 7th grade when I was 14, I think. My symptoms began after I broke my tailbone. And we now know that 85% of IC patients are like me. That our underlying problem is really coming from nerves and muscles as compared to an actual defect with the bladder wall. And so this is why we do something called phenotyping. So we don't just tell everybody, hey, you got this incurable bladder disease. Hey, here's the diet. Hey, here's some antidepressants, and send you on the way, because we know that doesn't work. And we've known that for the last 30 years. Bladder treatments don't work for the great majority of patients. They didn't work for me. And I did them for decades. What finally healed me was pelvic floor physical therapy, because my phenotype is pelvic floor driven. So we want to make sure that you get phenotyped correctly. And the urodynamic, not particularly helpful. Urodynamics, yeah, it can help establish some neurological issues. But I want you to take us back to 30 years ago when you were in your early 30s. That's when my bladder pain started too. But okay, so I had frequency urgency in 7th grade, all through junior high. In high school, I had severe vulvodynia, felt like I had a yeast infection all the time. In my early 20s, I had irritable bowel syndrome terribly. That probably lasted 7-8 years. Then I got migraines. And then in my early 30s, I got bladder pain for the first time. And it all was the result of breaking my tailbone. The injury did not get treated correctly. My muscles went into tension that lasted for decades, and it caused the central sensitization systemic nerve issue that went all the way back to that original injury. But I'm better now, and I'm better now because my bladder is healthy. And the last time I had my hydrodistension was when I had my hysterectomy 6-7 years ago, and he showed me pictures, and he said, you've got a perfect bladder, Jill. This proves it was never your bladder. It's always been your nerves and muscles. Christine said, initially 13 with bladder, broken tailbone pain, complex PTSD. Girl, we're twins. We're twins. And this is very, very common. We now realize that 85% of IC patients are like you and me. And you've got the fibromyalgia. That's part of the widespread pain. So we use a 5-point phenotype. I use the 5-point phenotyping that was created by Dr. Christopher Payne, who did the IC research at Stanford University. So he focused on 5 core subtypes, but he said there are probably more. But these were his original subtypes 7-8 years ago. Number 1, Hunner's lesions, wounds in the bladder. We now know that those are often caused by viruses, a viral infection in the bladder. Number 2, bladder wall driven. In the bladder wall driven phenotype, we're first going to look for a chemical injury to the bladder, chemocystitis. Then we're going to look for estrogen atrophy, and we're going to look for chronic UTI, chronic fungal, and chronic fungus. That's very, very small subtype. Our third phenotype is pelvic floor driven. This is the biggest phenotype by far, 85%. So for these patients, their symptoms are being caused by pelvic floor tension that has gotten so severe they've entered a state of ischemia. The muscles are so incredibly tight that they started to restrict blood supply to the surrounding tissue, to the bladder wall, to the nerves. And that creates neuroinflammation, that creates a whole lot of problems down there. Phenotype number 4 is pudendal neuralgia. These are patients who have muscles that are so tight they're squeezing nerves. So if you have sciatica, if you have pain when you sit down, that gets better when you stand up. If you have pins and needles, if you have areas of numbness, if you have PGAD. But positional symptoms, we're going to look at the role of body position and muscles and nerves in that body position. Then our last phenotype is widespread pain. People with IC, IBS, vulvodynia, TMJ, migraines, sensitive skin, wicked sense of smell. We now know that the widespread pain phenotype is really the result of an injury to the central nervous system. And so therapeutically, what our guidelines say is that we've got to take a top-down approach to widespread pain. We have to calm the entire central nervous system. Bladder therapies will not do that. And so this is where we're going to do the PEA, palmitoyl ethanolamide, maybe gabapentin, maybe low-dose amitriptyline, things that calm nerves down systemically over time. And Renee said that's her too. This is so 30 to 40% of IC patients also fit the widespread pain phenotype. And so the question is, why does widespread pain occur? What the research shows is that for some, it occurs after a major physical injury. 14 days of pain will cause changes to the central nervous system. And then for the others, it's a history of abuse or bullying. And so the exciting thing now is, I mean, it's a delicate dance here because we have to teach you that this is all about your entire nervous system, not your fault. You've done nothing wrong. No shame, no blame. It is injury. It is an injury to nerves. And that injury to nerves can often happen in childhood. It commonly happens in childhood, whether it's that broken tailbone. I was working with a woman who was in her 40s or 50s who had a broken back in high school. Her mother refused to take her to the doctor for 3 weeks, forced her to go to school with a severely broken back. She had terrible widespread pain. I was working with a gentleman who was hit by a car and had a crushed pelvis. He had terrible systemic pain. So we want to take the shame and blame away because, for God's sake, it wasn't your fault, not my fault at all. But we also have to inspire you and me to do techniques that calm the nervous system down. And that's where it gets a little bit hairy, because if I tell you to do mind-body medicine, you're going to say, shut the F up. It's my bladder. I'm not interested in doing this whole meditation stuff. and which is my first urologist when I was 32. And guys, this is after I had a master's degree in psychology. And I was going on for my PhD. And my urologist said, I want you to go talk to a psychologist about this. And I went, no, I'm peeing all night. It has nothing to do with my mind. I'm not going to go there. I want you to help me stop peeing at night. And I blew him off. But you know what? He was absolutely right. Because he could see that I had the history of the IBS and the vulvodynia and the trauma and all that sort of stuff. He could see that I needed to learn new techniques that would calm my central nervous system down, that would break me out of chronic anxiety that I was struggling with, a terrible anxiety for many years. And that's a hallmark of somebody with widespread pain is we struggle with anxiety. And that's the result of trauma. You know, that's your brain trying to protect you from trauma. So the blessing here is that we know the therapies that are going to help the most. So for you and me, you know, bladder therapy is pointless. We have a healthy bladder. We have to work on muscles and we have to work on nerves. And I would really encourage you, if you feel like you're in this group, check this out. PEA 500, Peora, PEA 500, also known as palmitoyl ethanolamide. So PEA has been studied extensively in Europe for the last 20 years for all sorts of pain, acute pain, chronic pain, surgical pain, burning mouth syndrome, fibromyalgia, shingles, you name it, they have studied it. Well, in 2019, they did a study with IC that was absolutely remarkable. That 87% of IC patients reported a significant reduction in their pain and discomfort. 3 months PEA with no side effects. And so when that study came, I knew about this. I had heard about this like at least 15 years earlier because we had a couple of doctors who were importing PEA for their IC patients here in California. But it was thousands of dollars. It was very, very expensive. And it was like, no way can people afford that. So it really fell off the radar for me. And then in 2019, this PEA study appears at the AUA annual meeting. And I dove right back into the research and looked at all these new research studies and was like, wow, wait a second, incredible safety profile. Only 1 out of dozens of studies found any side effects. They all talk about how well tolerated it is with no known drug interactions. And so I took that study to the company that makes Bladder Builder and I said, hey guys, can you make us an American version of what they're using over in Europe? Because we couldn't get this stuff from Europe. And they created PEA. They created this for us based upon that study. And we have thousands of patients using it now. The general consensus is that it acts by calming the nervous system down. A lot of people ask me what I do. This is what I do every night. But I also stop it for a month or two. And it's helped me the most with really, really, really sensitive skin. My skin is so much happier than it used to be. I used to struggle with a lot of small fiber polyneuropathy, pinpricks in my skin. And by the way, that was presented as a new research study at AUA a couple of weeks ago. They're proposing that patients with that super sensitive skin, that they have a little skin biopsy, and if a small fiber polyneuropathy is found, that dumps them immediately into the widespread pain category, where we know immediately to do systemic therapies that calm nerves down, like PEA. So anyway, this is in the ICN shop, and the really cool thing about it is it's literally the cheapest supplement, one of the cheapest supplements we have other than Pre-Leaf. It's under $30. So worth a shot if you feel like you have a really sensitive nervous system. My opinion is not for sale. I've had many, many companies over the years offer to send me free product because they wanted me to become a spokesperson for free, and I said no to every single one of them. I have never ever given a personal recommendation like that until this, because my skin was so messed up a couple years ago. I could barely sleep because I kept feeling like I was being poked by pins all night long. And there were some nights where I couldn't sleep without Norco. And I was just so exasperated. I just said, all right, I'm going to try it. They didn't pay me to try it. Nobody paid me anything to try it. And I'm stunned at how effective it has been for me personally. God's honest truth. I'm so excited about that. So I have been making the case and I put together all the research that I could find, and I've sent it to a number of pelvic pain experts around the United States and around the world, because I really believe that it should be incorporated into our pelvic pain guidelines as an over-the-counter supplement to try before going into some of the more side effect prone gabapentins and things like that, and the antidepressants. Worth a shot. It's worth a shot, but you read about it on your own. See what you think. You know what I'll do is I will type the scientific name in. So it's palmitoyl ethanolamide. Google it. Google it. Look at the research. One of the original researchers in the Italian study in 2019, I got an email from her a couple weeks ago. She said it's become the cornerstone of their treatment for IC now. Absolute cornerstone of their treatment for IC in Italy. All right, Elise said, hold on. Craft Artistry said, recently told I've got IC, levator ani, hypertonic pelvic floor, vulvodynia, chronic SI joint pain, struggle to sit, walk, told it was caused by a bacterial infection and 22 numerous treatments. Honey, I would really disagree with that. I do not believe a bacterial infection is going to mess up your SI joint. I would, and nor the vulvodynia or the hypertonic pelvic floor. I think it's far more likely at some point in time you sustained some sort of pelvic injury. If you were an athlete, if you were ice skater, gymnast, horseback rider, bike rider, anything that involved falling. If you were a cheerleader doing flying splits, generally what we see are a series of minor pelvic traumas over time that slowly but steadily damage the muscles and make them tighter and tighter and tighter and tighter. And then finally, there's one little event that becomes the straw that broke the camel's back that turns all the pain on with those muscles. So Craft Artistry, please think back about any injuries, traumas, or sports you were involved in. I bet we could find a trauma there. Elise says, lots of internet connection for a little while, so I'm a little behind. Yes, I'm using both clobetasol and topical estrogen now. Unfortunately, lichen sclerosus was misdiagnosed for many years. I'm sorry, hon, but the good news is they have it now. And so you're doing exactly the right treatment now. And the research shows it really, really works. You know, my hair is getting to the point where it's getting so long that it's pulling on the back of the chair when I move. I've decided this summer I'm embracing my inner hippie. And then I'll get a cut right here again. If you go back videos, you can see I get a cut to here. It takes 2 years, grows down to my waist, then get a cut to here. I love long hair, but it's annoying because it pulls all the time, and that's why you see me touching my hair so much. Belle says, I went to pelvic floor physical therapy 2 years ago. The internal work she did with her finger was so painful, I had to quit. My doctor wants me to try another PT. Should PT be that painful? Yes and no, honey. Yes and no. Listen, at that first physical therapy appointment, their job is to study your pelvis. It's a new set of eyes. And so they're trying to understand your body mechanics and your physical structures in your pelvis. So generally, they will watch you walk. see if you're walking normally. They will measure your legs. Do you have one leg longer than the other? And of course, your ability to describe your symptoms gives them a roadmap on where to look. So it's very important that you describe your symptoms as clearly as possible. And then when they do that internal exam, which is the single most important part of the exam, all they're going to do is touch muscle. That's all they're doing is touching muscle. And if they touch a muscle and trigger your pain, that is what I call your hallelujah moment. That is so exciting because they found it. They found it. Like, oh my God, that's it. All that hurts. What are you touching right now? And so you should never be afraid of pain at that first appointment. That's exciting because they found it. Your question is, okay, what are you touching? What is that? And so, yes, you need to go back to physical therapy because you're going to need to have another assessment. They're just going to touch muscle. Let's see what we're dealing with. And once they know if it's the levator or the piriformis or the obturator or whatever, your second visit, they're going to start working with that specific muscle, and they go slowly. So don't be afraid of that pain. That's good. That's meaningful. That's important information. If you walk away from physical therapy, that muscle is just going to get tighter and tighter and tighter. And believe me, that's not going to be helpful for you over the long run. We got to get these muscles as healthy as possible. Christina said, yes, I have hypertonic pelvic floor muscles. Do you have much information on the high assist installs? The high assist installs aren't going to do a damn thing for tight pelvic floor muscles, hon. What they might do is help numb your nerves. Let me just look up something here real quick. Did they give you another name besides high assist? Okay, so high assist and cystostat, they are just hyaluronic acid. And it's not acidic that'll irritate that it will irritate your skin. Don't worry about the term acid in that. It's either sodium hyaluronate or hyaluronic acid. These are naturally found throughout the human body as kind of moisturizing molecules. They're found in joints. They will inject hyaluronic acid into your jaw joint, for example, if you've got pretty bad TMJ. So it's kind of a lubricant. So that's one type of coating that has been available in Europe and Canada, but it never was good enough to make it through the US FDA approval process. And then another company came through and they created something called Urassist. And Urassist uses chondroitin sulfate rather than hyaluronic acid. And it turns out chondroitin is actually a building block of the bladder wall. It's essential to the superficial integrity of the bladder wall. So chondroitin is considered the more important agreement between the two. So anyway, we had these two competing products. We had the chondroitin, and then we had the hyaluronate. And these companies were just constantly trying to outcompete each other. Every year they'd have new research. We're better, we're better, we're better, we're better. And on alone, none of them were good enough to make it through the US FDA approval process. And then some but brilliant person combined them. So they made a bladder installation that was chondroitin and hyaluronic acid. And that was far more effective. So the brand name for that is called Ialuril, Ialuril. So I would be looking or asking Christine about a combination of hyaluronic acid and chondroitin. Do I see any harm in it? No, other than the fact that your urethra is going to get pretty irritated. I mean, it's been out there for decades under a couple of different brand names. But what the research shows is that it's a combination of the two that appear to be the most effective. Honestly, I haven't looked at the research in the last 5 or 6 years. Maybe there's a new study that might be showing that it's a little bit better. But Ialuril, Ialuril, is probably the most popular brand name installation in the world. But the most popular installation in the world without a brand name is called a rescue installation, and that's just heparin and lidocaine. Dana said, it is possible to have bladder wall driven IC and overlapping chronic pain syndrome. I'm currently in a flare, but I also suffering from my first UTI. I'm not even sure where to get started. It is, absolutely. You can have any combination of phenotypes in the IC world. Absolutely. The most common combination is pelvic floor widespread pain. And you have to remember that if your muscles are really, really tight, they're going to cause bladder wall symptoms. But bladder treatments don't work. And so that's why our guidelines say your very first appointment with your doctor, they're supposed to check your muscles. And if your muscles are tight, you're supposed to immediately be referred to physical therapy. So it's that muscle assessment that is critical now to help us figure out where you need to go next. Otherwise, it's confusing because you're going, well, it's bladder wall pain. Well, maybe it's not. Maybe you've got coexisting tight pelvic floor muscles causing that bladder wall pain because you're in a state of ischemia. Hello, Katsa. Hello, Alexandra. You probably don't remember, but you helped me with my symptoms about 2 years ago, and now my husband is having problems. He just turned 50, and they can't figure out what is going on with him. They just threw him into a prostatitis group. I'm going to try to get him to call you. Sure, I'd be happy to talk with him. For guys, really what we see in most guys who have been diagnosed with quote unquote interstitial cystitis, and I'm saying 90 to 95% of the guys, we're looking at a muscle nerve problem by far. Injury, trauma. Does anybody else get, one of the things that drives me a little bonky is that if I get gas in my stomach, just like a little belch in my stomach, my stomach kind of quivers. It just kind of goes, but it's like right up here in my chest. And so I go, is that my heart? And it's never my heart. And then I belch afterwards and it's fine and it goes away. And I saw a doctor 30 years ago for it, and I know exactly what it is. I just wish it didn't feel like it was my heart because it just did it while I was talking. It's like little, like right over my rib cage, but not over my heart. And then I could tell exactly what it was, and now it's gone. So annoying. Jamie says, pain seems to be outside left side with burning. What does that point to? Points to something on your left side. Very common. So my pelvic floor pain is dominantly on my left side also. Dana said, should I go have a bladder installation while I'm still recovering from a UTI with gross hematuria? I don't think a doctor would do that until you're free of that UTI. Mala said, have you tried herbs? I stopped using Western medicine. Oh, honey. Oh, please don't promote herbal remedies. Renee says, I've had it. It seemed scary at the time. Yeah. Katsa said, they told him his PSA is 4.3 and they said it was high for his age. Well, prostate issues are inevitable in men as they get older. And it's just something that you have to keep monitoring. And they check PSA levels and all that sort of stuff because, number one, you can get benign prostate hyperplasia where the prostate just slowly starts to swell. And what happens is it starts to grow into the urethra and it makes it much harder to urinate because the urethra is being blocked by prostate tissue. But there can also be pelvic pain, prostate pain. And of course, they want to make sure that prostate cancer isn't happening either. The prostate cancer is, it's heartbreaking. prostate cancer to men is like breast cancer to women. It's just life-changing, altering, and often with deadly consequences. And so we want to, oh, in fact, guys, so I had a mammogram on Thursday. Every single time I get an email, we think we saw something, we need to come back. So I'm going back. I'm like so over worrying about it because it's just little calcifications. Every single time they call me back. And then the first time they called and said, hey, we think we saw something, they were going to make me wait a month. And I'm like, wait, you just told me you think I have breast cancer. Now you want me to worry about it for a month? How is that fair? They got me in the next day. This time it's just a little bit of calcification. So anyway, Belle said, I have that fluttering too. I had EKG stress test. Doctor said it was a nerve in my stomach that becomes irritated and sends a signal that feels like it. Exactly, Belle. Isn't it annoying? And for me, it just, as soon as I get the gas out of my stomach, it stops. It's like there's gas in my stomach that makes my stomach kind of quiver. And I had the EKG. I've had the stress test too. I've had it all. And the only other thing they said to me is you may never drink caffeine again, because I also throw PVCs if I have caffeine. So I'm glad I'm not the only one, because it annoys me. I just, like, my goal for the next year is I don't want any more health visits. I don't want any hospitalizations. I've had three ER visits. I've had 2 ambulance rides in the last 3 months because of my freaking gallbladder, and they thought it was COVID. And this whole time it was my gallbladder. And I had a racing heart from it too. Vesna said, my son is now on installation on Ialuril. He just had his 4th Wednesday. He has Hunners, no improvement with the quantity still. Well, Vesna, when you have Hunners, the Hunners have to be treated. And the Hunners are generally treated with a steroid injection or fulguration. So come on over to the IC Network and make sure you read that section on Hunner's lesions, because Hunner's lesions are really not known to respond well to bladder instills. Hunner's lesions require lesion-specific therapy. Another treatment for Hunner's lesions is hyperbaric oxygen. That has been found to be successful in patients with Hunner's lesions. Somebody's talking a lot about intravesical ozone, but we just don't have any research supporting its use for anything. So I don't quite, I mean, you see fads come and go, and I kind of see that as a fad. I'd like to see more research on that before we go there. All right. So we've been on it now for 2 hours. Oh, okay. So this you're not going to like, my friends. This part you're not going to like. I'm just telling you right now, but it's not for the reason you think you're going to like. So, love it or hate it, social media has been incorporated into modern life. In fact, 78% of American adults have social media in 2024, and the average user spends 143 minutes a day on it. While some social media can have benefits of offering support for IC patients, some recent studies have found that it is linked to an increase in inflammation throughout the entire body. Dana, they can use it for hyperbaric treatment. I mean, they can do it for bladder wall inflammation. Sure, I don't see why not. It's just been studied specifically with Hunner's lesions. Okay. Whether IC is caused by inflammation or not, we do know inflammation increases pain. For example, the body's stress response increases inflammation throughout the body, which could be at least partially behind stress-induced flares. Being aware of what causes systemic inflammation is important for IC patients. And in the past couple of years, a group of researchers from New York and Ohio have completed a series of studies examining the impact of social media on inflammation throughout the body. The majority of those studies have previously focused on mental health, but they haven't looked at the concept of physical health. And what did they find? In 2021, the first study paid particular attention to who was most susceptible to having increased inflammation from social media use. Researchers found people with lower self-esteem were more likely to have systemic inflammation increase with social media use. Generally, people with lower self-esteem, guys, I'm going to phrase this a different way. I'm just reading it from their press release. People with lower self-esteem experience more anxiety and stress in social situations as they worry about being disapproved or rejected. Those with higher self-esteem tend to receive self-affirmation. Oh, screw that. Okay. I hate the way I hate the way they presented that, because this is what we know. Oh God, there's just so many ways I could go with this. We have so much research now which has proved that adverse childhood events is a foundation for a lot of widespread pain and chronic anxiety. And that makes it sound like there's a oh God, I don't even know how to describe this. I mean, I'm quite offended with the way they state that, because self-esteem is dependent on so many factors, not the least of which is your safety and your security. And if you are a victim of an adverse childhood event and you lived with somebody who abused you for a decade, how is that going to affect you? You're going to be anxious because you were hurt. So I don't see a direct correlation between self-esteem and anxiety. What the correlation I see is trauma for both of those. Okay, anyway. The point here is that people who used a lot of social media had higher levels of inflammation. And why? They're not sleeping. Maybe the quality of sleep is poor. Maybe they're less active. Maybe they're not eating as well. Maybe the hyperconnectivity is causing increased stress levels, which would certainly increase inflammation, et cetera, et cetera. The point of this is, should you stay on social media? Is it going to make you flare? The answers are yes and no if done with awareness. Social media is a great way for IC patients to connect. In fact, I created the first online support groups years ago for this. And social media can help. It can be a great resource. However, while you can find resources online that can uplift you and help you, which I hope I do, there are also things online, the groups online that are negative and self-righteous and deliver false information and insults, and you just don't want to be there. You just don't want to be there. So anyway, I think we're kind of like getting back to how I started this meeting, where we're talking about the consequences of decisions made years ago and the consequences of antibiotics years ago, creating a messed up biome. Well, I think we're also going to have a reckoning about the consequences of social media and being on the internet all the time. How is that affecting our body? It's undeniably affecting our body in ways we still do not know. And I will say here, and I want to say this, guys, I don't spend a lot of time on Facebook so much anymore, except doing these meetings. And once or twice a week, I'll come and check and see what's going on. I really, really try to protect myself, because I find some of the posts on Facebook to be really too stressful. And the last time I spent any time on here, somebody made these sweeping statements about my political party and said we were all the devil. And I'm like, what? I do not need to listen to that. I am done. So anyway, be with people. Get out and walk. Get out and walk. Get out in nature. That's the most healing thing of all. Diane says, so did you say that with widespread pain subtype, gabapentin can help if you don't get enough relief with relaxation techs and cognitive behavioral therapy? Yes. I'm in therapy and use psychotherapy and mind-body medicine. Should I see about adding gabapentin at night? No, I don't think you need to add any more, hon. You're already taking other stuff, but I think it would be really interesting maybe to try the PEA, because there are no known drug interactions with the PEA and there were no side effects in the IC study. So adding this might be a little interesting to see if that maybe gave you a little bit more improvement for where you are right now. I mean, that would be interesting. Google it. I'm going to give you the scientific name again. It's palmitoyl-ethanolamide. You look at the research and see what you think. But I think it's pretty exciting. And this is in the IC Network shop, guys. For anybody who wants to try it, it's like $28.95. Vesna says, after hyperbaric oxygen, after hyperbaric chamber, the pain has stopped, but the Hunner still exists. Well, that's fantastic, Vesna, that his pain stopped. Okay, so we've made a really good stride forward. I would imagine, did he have a hydrodistension after he did the hyperbaric oxygen? Because what the research shows is that the Hunners, I think, get smaller and reduce in quantity and sometimes go away. You might need a little bit of time for those Hunner's lesions to heal. Healing is not instantaneous. If for anybody out there, if you'd ever like to talk, reach out to me. You can pop me an email, icnetwork@mac.com. Always happy to talk offline and just share ideas and research and whatever we can, because our goal here is to try to open up some new doors for you so that you can maybe find some more effective therapies. But I'm not a doctor. I can't give you medical advice. My job is to educate you, to inform you, and then to kick you in the butt and get you back to your doctor with a new set of questions. Hey, doc, what about this? Can we consider this? Diane says, I do take PEA and it does help, but not enough to sleep well. Interesting. How often are you getting up at night, Diane? And do we have an idea as to why? I mean, are you peeing more at night than you are during the day? When we see increased urine output at night, when we see patients who literally drink very, very, very little, and during the day they're fairly normal, but once they go to bed at night, they start peeing more. That's when your doctor has to look at a few other conditions. So for example, my mother was doing that. She was barely drinking during the day, and yet let me tell you, it was getting her up at night, and she would fall. We had the porta potty right next to her bed. She was 94. She was in a little bit of heart failure, and that happens sometimes when you're in heart failure, but that can also happen with diabetes. There are a number of conditions that can cause that nighttime urination. And so I would want to make sure, again, the question is, do you have frequency all day? Like literally 24 hours a day, you're getting up every 30 minutes, or is it really dominantly at night? If it's real, and then I was working with another patient, just again, it was like massive urine production at night. And that took her down another diagnostic direction with her doctor, because they have to figure that out. So that might not be IC at all. That literally could be something else. Or is pain keeping you up at night? I mean, if it's just, so what's keeping you up at night? Is it just you're peeing all the time because you've got stuff in your bladder all the time? Are you getting up at night because it actually physically hurts? That's an important distinction. So let us know. Tracy says, I want to plug the PEA. Jill recommended this for me a year ago. It's been more helpful than I expected. I also take Cystomend, and they had recently added PEA into their ingredients, so I stopped taking the PEA supplement. But my pelvic pain came back with a vengeance. I started using the PEA supplement again. I've been doing better. I love Natural Approach Nutrition. I love the CEO at that company. They are always trying to make their products better. They're always trying to tweak formulas. But they just can't put, there's limited space in the capsule. You can't put as much as you'd like in a single capsule. And so the fact that taking that little bit of extra PEA is just so much more helpful for you doesn't come as a surprise to me at all. That's good. I'm really glad you're doing better. Diane says she can go 1 to 2 hours during the day and 5+ times at night. My bladder hurts, and after I pee, the pain goes away, and I can go back to sleep. Okay. So that brings us back to the concept of an irritated bladder wall. So the number one cause of nighttime urination for an irritated bladder wall is always going to be something that you've eaten or drunk that day. Because it's at night that there are fewer distractions and you start noticing it more. And so that 1 cup of coffee in the morning, cup of green tea in the morning, taking a multivitamin, things like that. So Diane, are you being really good with your diet? And Donna said, what's a safe prep for colonoscopy? What a great question. And I actually have a whole section, a whole blog on this over on the IC Network, because this question comes up all the time, Donna. And then the prep that I did and the prep that gets the best reviews from patients is the Miralax protocol. So with the Miralax protocol, you swallow 4 biscotal pills at like 5 o'clock the night before. And then you do Miralax dissolved in your choice of either a Gatorade or even just water. So I did it in Gatorade, worked like a charm. I just have a couple of suggestions about it. Number 1, get 2 flavors. I did lime, but that's from my old tennis playing days. My body just likes lime Gatorade. And remember, I'm not the bladder wall subtype, so I can drink Gatorade. If you're the bladder wall subtype, you might not be able to do it, but I can do it. You need 2 separate flavors, because getting down 2 solid bottles, the same flavor, it gets a little cloying and annoying at the end. So I would do green, and I would do blue, or I would do clear. You'll be at the end of 4 or 5 hours, you'll be pretty empty. Hopefully you'll get some sleep before your test the next morning. Nothing to worry about with the test. They usually do a very light propofol anesthesia, so that you don't feel it. So the hardest part is the prep. The easiest part is actually having the colonoscopy. Just know that for a couple of days afterwards, you're definitely still going to want to stay close to a bathroom, because your guts are coated with this. And so I would say for two days at a minimum afterwards, I was still running to the bathroom suddenly. And then it got better. So anyway, the Miralax protocol. Hey, Kayleen. No worries, hon. No worries. I was hanging out with my cousin last night. All right, my friends. Well, listen, we've been going for a bit over 2 hours now. So let's do a last call for questions. So what I'm working on, we will have our IC Optimist at the typesetter this week. Um, then I'll be putting up new masterclass videos. I've got about 20 more filmed. So our new free masterclass, IC 101, is now available on YouTube. It's also available on the IC Network website. If you just go to the front page, it's in the main menu, IC 101 Masterclass. Right now, there are about 16 total videos up there. There are 5 to 10 minute videos each on separate topics related to IC and bladder pain. And that's a good place to start. And so I will have many more of those videos that I intend to put up. Good job, Kayleen. Sherry said, I just got off antibiotics, then stuff, and a steroid for all of them. Sherry, your message got a little bit messed up. Ravonda said, I haven't found any electrolyte mix that doesn't have citric acid in it for colonoscopy. Any suggestions? Well, honey, you can just do water if you need to. You can do water with mint in it. You can do water with chamomile in it. You can do anything at all like that. It just can't be red or orange. But for those patients who are the most sensitive and you just can't tolerate an electrolyte mix like Gatorade, then play with and talk to your doctor about it. Make sure it's okay. But I think you could do like an infused herbal tea with peppermint, like a sun tea made out of fresh peppermint leaves. If you can get that down, that would be great, because the peppermint's also a very nice smooth muscle relaxant and can calm some of the bowel spasms that happen after colonoscopy. But if you have GERD, you can't do peppermint, so maybe you could do chamomile. Also, there's a new colonoscopy prep that's more pill-based. You don't have to drink a lot of fluid with it. It's a new type of prep that is pills. So maybe that's something you can explore too. It's really rare though. I can't remember one person in the last 20 years who called saying they flared after a colonoscopy, regardless of prep, whether it was Go Lightly or anything like that. And so I don't think you really need to worry about, don't worry about it too much. Your mind is going to be paying attention to what's happening in your bowel. It's not going to be paying attention to what's happening into your bladder, most likely. Diane said, wondering how you can drink lime Gatorade. I have estrogen atrophy and I've been an estrogen cream for over 1.5 years and it's better, but I'm still sensitive to acid drinks and foods. What do I have to do to be less sensitive and drink and eat more without flaring? Well, number one, my bladder is very, very healthy. My bladder has always been healthy. It's always been my pelvic floor. But yes, I am in estrogen atrophy now. And I'm not as religious as I should be on using my topical estrogen. But that said, I have been able to, what is this? This is very dilute lemonade. Listen, you guys, I mean, the game changer for me. So we knew about this subtype 7 years ago, right? But I was diagnosed 30 years ago. I had not had lemonade in 30 years. I would have one 7-Up every 5 years. One soda in 5 years. That's how I've been for the last 30 years. No cranberry juice, no Cokes, nothing like that. And even though I knew I was pelvic floor driven and widespread pain, it would never have even dawned on me to try lemonade, because it became a habit. Like, I'm not drinking it. I didn't drink orange juice, pineapple, nothing like that. But then exactly a year ago, like within 3 days, I had COVID. My mother was dying in the hospital, and I went to visit her wearing a mask because she was dying. And I started coughing so violently, I almost passed out. And I mean, I was there for less than 5 minutes. It was the last time I saw her alive. And I ran into the bathroom. I was just retching. I was coughing, such a bad COVID cough. I tear out of the hospital, get into my car, and I'm coughing, going, oh my God, what do I do? And the only thing that came to mind was hot lemonade with honey. And I thought, I got nothing to lose. Realized I was already irrational because my mother was dying. I stopped at the supermarket. Again, I was masked, bought lemonade, bought honey, came home, heated up in the microwave, drank it, no flare. I have been drinking lemonade every day for a year. Not a single flare from it. So what does that mean? What that means is that number one, I have a healthy bladder. And number two, all the pelvic floor work that I did has worked successfully because I have restored good blood supply to my bladder and everything's much, much better. And that's why I can drink lemonade now. It's surreal. Now, I don't drink full strength lemonade. I mean, like literally in this, it's like this much lemonade and that much water because I'm not an idiot, because I know I'm in estrogen atrophy. And I'm also eating spaghetti with tomato sauce and salsa. I'm doing all of that now. I avoided all of that for 30 years. Now, I've had some pelvic floor flares, and I flared this weekend. Honestly, I did. And my pelvic floor is very, very unhappy with me. My SI joint is very, very unhappy with me. And I could feel my bladder getting a little bit more sensitive. But that's not because my bladder wall itself is damaged. It's because my pelvic floor muscles are messing with my nerves again. And so I called my doctor. I'm set up for an SI joint injection and I'm doing my physical. And when I went and did my PT, my muscles were just incredibly tight again. And I just think it was because, I couldn't do anything for a month after my gallbladder removal 2 months ago. So my fitness and everything, I just couldn't do anything. It's ridiculous. I just sat around, and I think that tweaked my muscles badly. Diane said, I'm doing pelvic floor physical therapy now, so maybe I would be able to be less sensitive after successfully completing it. I hope so. I hope so. Now, do I think I'm going to be able to continue this? I don't know how long I'll be able to continue it because estrogen atrophy is real. I am, my short-term memory is sucky right now. I'm shocked. I think the anesthesia just messed with my brain a little bit because I keep walking into rooms and forgetting why I walked into the room, which I did twice this morning before I did the support stream. And so life is an adventure and there's traumas, and all we can do is just go back to that really good, healthy routine, getting out, not sitting a lot, get out into nature, let your body heal, eat really good, fresh food, try to eat organic whenever you can. And work on that stress level. I suck at meditating. I'm just not interested in meditating at all. Diane said she had the same thing from anesthesia. Yeah. Renee says that is it. It takes time to get out of your body. Definitely. So what I do instead of meditating is I paint. And so when I feel myself getting worked up, and believe me, I can get worked up. I've got a little painting station in my family room. I'll go here. I'll show you let me go get the painting I'm working on right now. I'll be right back. I'm quite proud of it. It's quite pretty. Hold on. Oh, it's my SI joint. Oh, it's so good, Mom. So this is my relaxation. How cool is this, huh? I'm in love with the blues. I'm absolutely in love with all the blues. So when I need to relax, especially at the end of the day, or if I'm just feeling a little sad or agitated. I don't get agitated that much. I just get more like frustrated. And well, this is a paint by numbers. This is not me. I can paint on my own, but I'm just trying to meditate. And this is a very these are not beginning. These are for the most experienced painters, and so there's a lot of detail work, just massive detail work. So you really have to tune everything out and do lots of very small things. One of my principles in my life that I've used really ever since my IC started is that I want to have something that I've made that I can look at when I feel terrible. I want to be able to go back to that period in my life and say, look, it was really awful, but look what I did. Look what I made. And my idea of a vacation is going to craft camp. I'm not interested in traveling. I just want to hang out with some friends and paint or quilt or whatever, play games. That's what I like to do. But I just the holidays were terrible for me from a grief standpoint, and my sister gave me one of these because she had started doing them, and God, it just gelled. And that's like my sixth one, and I have four more that I've already bought, and they're like $9. They're super cheap. So it's not like you have to pay a lot of money to do one of these. You can just buy the canvas and they send you the paint for under $10, and it's just a nice way. Put on a video, put on your favorite music, and just sit and chill for a half an hour or 45 minutes before you go to bed. It's really, we have to find that way that we relax, because life is too stressful right now. There's so much going on that's so destructive to our mental health. And it's not just being in pain and dealing with medical issues. It's just society right now is not happy and comforting. It's just not. It's especially in an election year. I mean, the blankets flying everywhere, and it's just not healthy for us. We don't need to pay attention to people bickering with each other and people fighting with each other and people bringing people down. And it's really sad that so many people like to be on the internet just to kick somebody when they're down and saying things that are disrespectful and discouraging. Kindness. I've been listening to a lot of Joel Osteen the last couple of days because, again, is the anniversary of my mom dying on the 17th. And he said something like, your character shines in what you do when you're alone. Not when people are watching, but what do you do when you're by yourself? Are you mean to others? Are you kind to others? And I mean, it just really resonates with me. I look at what I see online in media and I'm just like, that's not me. I do not want to be involved in that at all. The other thing this morning, he was talking about, there will always be people who don't like you. It's okay. It's okay if somebody doesn't like you. You don't need to worry if somebody doesn't like you. Just let you live your life, let them live their life. He said 25% of the people you meet will like you and they will immediately like you and they will always like you. 25% of the people you meet will not like you and they will never like you. And then 25% of the people you meet, they will like you at first, but their opinion can be changed for the worse. And 25% of the people you meet won't like you at first, but their opinion can be changed for the better. And he said, fundamentally, the flaw with social networking is you keep focusing on the 25% who will never, ever, ever like you. You keep trying to convince them to like you. Stop it. Not everybody has to like you. You cannot be successful in life without people not liking what you're doing. I can remember Dan Brickoff, who was our leading pain specialist in IC. He became a very good friend of mine before he died. And he said to me, Jill, if you haven't pissed off at least one person a day, you're just not working hard enough. But you can't let their opinion stop you from pursuing your life. Nobody online should have the power to affect your self-esteem. The only person that should affect your self-esteem are the people in your immediate life that you spend time with physically. The rest of us are, we're in the wind. And we cannot let somebody we meet online upset us. It's not worth it. You have to focus on your health and your physical, mental, and emotional health. And that means, in my opinion, we need to be outside. And let's just go do fun things and bring joy and laughter and kindness in our lives. If you can help one person a day randomly, girl, that's a good life. If you can be proud of what you've done, if you can look yourself in the mirror at the end of the day and be proud of what you've done that day, that is a good day. So sorry, I can preach like forever. Kristen said, adult coloring books can be meditative too. There are lots of types to choose from. Yeah, I don't know. Adult coloring books really kind of, my neck is always very tight and I have to be careful about it, so I can't do it a lot. But I have to focus more with coloring books for some reason. Ravonda says, thanks for sharing. We are also different in our healing journey. I tried a couple of ounces of fresh lemon juice and about 100 ounces of water each day for a couple of days and flared badly. Look forward to the day. So I don't do fresh lemon juice, hon. I buy a lemonade that's pre-made, that's already diluted. And even then I'll use this amount. So, but have faith. Have faith. Once we get your bladder calmed down and we get that bladder to heal, then you should be able to expand your diet. And if not, you can use some Pre-Leaf, which is back on my shelf right there. Pre-Leaf, who sponsors these meetings. I should mention them more. Pre-Leaf is a great way to reduce the acid in the food that you're eating or drinking, so that it won't be so irritating, so that you can go out and enjoy a nice meal with your family and friends and not worry about that. So if nobody's tried Pre-Leaf, it's a simple calcium-based supplement that acts to reduce the acid level in your urine. And tens of thousands of patients have used it very, very successfully. It's the oldest supplement we have. And it just works for so many. Of course, you don't eat it like candy. You just take it before a meal if that meal is going to have something acidic in it. So if you've got to go to grandma's house and eat her lasagna and you don't want to offend her, take a cup of Pre-Leaf right before that meal. That will reduce 95% of the acid in a cup of tomato sauce. That's a good way of doing coffee too. But my position on that is, if we're trying to give your bladder time to heal, the last thing we want to do is pour coffee with Pre-Leaf in it. We don't want to pour anything irritating on it. The only thing we would pour on a wound on our hand is water. We have to give our bladder time to heal. And so it's important to be off of the coffee and the sodas for at least 3 months, really give that tissue a chance to heal before you try it again. And when you're ready to try it again, you're going to do a low acid decaf coffee like the Bella Rosa coffee that we have in the IC Network shop. So, all right, my friends. Well, it's a beautiful day here. I need to get out in the sunshine. I'm going to go sit in the sun just a little bit myself. So hopefully you will see me next week. Knock on wood. I wish you a fantastic week. Summer is here. May we all have fun, warm, joyful days in the coming months. All right. So I'm going to say goodbye. If anybody needs to get a hold of me, you know how to reach me. icnetwork.org. My email address is icnetwork@mac.com. If you find these meetings helpful, come on over to the IC Network and become a member so you can get our magazine, because that's where I do our best work, in our magazine, the IC Optimist. All right, guys, I will see you later. All right. All right, Facebook is done. All right, YouTube, you guys were very quiet today. I wish you well. See you later.